course, we spoke about the ancient Greek perception of mental illness. Although concepts like bodily humours and hysteria have been disproven, some of their ideas were actually pretty close to our current understanding of mental disorders. Ancient Greek physicians described three primary mental illnesses: phrenitis, which is probably closest to our understanding of delirium; melancholia, a syndrome characterised by lethargy, loss of appetite, fear and low mood; and mania, characterised by excess energy, agitation, and sometimes accompanied by bizarre behaviour. Incidentally, this is where the term maniac originated. In 1801, Philippe Pinel described a disorder where episodes of manic and melancholic states appeared to cycle with periods of sanity in between. He noted that one of his patients, quote, suddenly changed its character and, quote, became a mighty potentate, sovereign of the world, equal to the creator, and supremely happy. Because of these delusions of grandeur and his patients losing touch with reality, Pinel called this disorder melancholia with delirium. Around the same time, a number of German psychiatrists, known as alienists, were attempting to make sense of the diseases of the mind and to group them according to the clusters of symptoms shared by their patients, just like the nosology of other areas of medicine. One such psychiatrist was Emil Kraepelin, who wrote a number of textbooks for his psychiatry students. In 1899, he described a disorder he referred to as manic depressive insanity. He wrote that this disorder was episodic in nature, with an inter-episode period of full recovery. And although we now call the disorder bipolar, his descriptions of manic and depressive episodes and the way that they cycle was pretty accurate. Under the DSM criteria, a manic episode lasts at least a week, whereas a hypomanic state lasts at least 4 days, and the symptoms are usually less severe. During this time, the person will get little, if any, sleep, but they won't feel tired. DSM-5 describes a manic episode as a distinct period of abnormally and persistently elevated, expansive, or irritable mood. The person shows a number of symptoms such as an inflated self-esteem, decreased need for sleep, excessive talkativeness, racing thoughts, distractibility, increase in goal-directed behaviour, psychomotor agitation, and or excessive involvement in high-risk behaviours. And at least 3 of these symptoms must be seen to an abnormal degree. So what is an abnormal degree? Well, this comes back to the concepts that we discussed in week 1. In recent years, it's been recognised that bipolar tends to progress over the course of a person's life. Early episodes, be they depressive or manic episodes, they're usually preceded by a stressful life event. When these early episodes subside, the person then enters an inter-episodic period with full remission of their symptoms. Mental health professionals will sometimes call this inter-episode recovery or a eurythmic state. Just as an aside, the presence of this inter-episode recovery sets bipolar apart from another disorder called cyclothymia. In cyclothymia, patients experience alternating episodes of hypomania and then subclinical depression, which simply means that the periods of low mood don't quite meet the criteria for a major depressive episode. Back to bipolar. If the person doesn't receive treatment and the disorder progresses, the episodes of depression and mania begin to appear more spontaneously rather than being triggered by life stresses. Full remission of symptoms also becomes rarer and rarer as time goes on. What I find really interesting is that at the turn of the century, Kraepelin noted that, quote, "There is no alienist, and it is my conviction that there cannot be one, who could tell from the picture of the patient's state alone whether the case in question is to be understood as simple mania, a periodic mania, or as circular insanity." What he means in this quote is that if a patient comes into his office for a single consultation and is in a manic state, it can be difficult to know if the person is experiencing unipolar mania, bipolar disorder or a completely different disorder like schizophrenia. In order to make this distinction, the clinician really needs to be able to observe the person over a long period of time, or at minimum, to have a reliable history of the person's mental health. Kind of disturbingly, clinicians now are still having the same issue over 120 years later. Bipolar is still significantly underdiagnosed because clients will usually seek help when they're in a depressive episode, and because they're currently depressed, they get diagnosed with major depressive disorder. It's usually only when that person becomes manic and gets hospitalized that the misdiagnosis becomes apparent. For a disorder that cycles like bipolar, a single snapshot in time is usually not sufficient to make an accurate diagnosis. Although significantly underdiagnosed, bipolar disorder is still a relatively rare condition, and it only affects about 1% of the population. It is a highly heritable disorder, and most people diagnosed have either a parent or other first-degree relative with bipolar or some other mood disorder. Interestingly, there doesn't seem to be a familial risk of both bipolar and schizophrenia. The family usually shows mood disorders or psychotic disorders. The reason I find this interesting is because this distinction between the two clusters of disorders was recognised way back in the 19th century when Emil Kraepelin differentiated between the disorders he called manic depressive insanity and dementia praecox, which we now call schizophrenia. Thanks for watching. In this video, we've covered the history of bipolar and its characteristics, as well as some of the diagnostic challenges faced by clinicians. In the next video, we'll look at some of the models of bipolar and how this disorder progresses over a person's lifetime.